Thank you, and I'll be very brief. My topic is radiation-induced fibrosis in head and neck cancers. We all know radiation is an integral part of treatment of head and neck cancers, and almost 70% of the patients have to go through radiation at some point in time. Radiation has action both on tumor cells as well as normal cells. So the goal is to achieve uncomplicated loco-regional control of cancer, which is not possible, and to shift the graph towards the left is the goal. We are all, as oncologists, radiation oncologists, supportive care team, we are all striving. I will just run through all this. This is just for completion's sake. Basically, fibrotic tissue sclerosis is the reason why you have head and neck radiation fibrosis, and the syndrome is called as a myriad clinical manifestation of progressive fibrotic tissue sclerosis. All sites are affected. Wherever there is radiation, head and neck, of course, is not left behind. So let us come to head and neck fibrosis. These are important aspects: time from radiation, total dose, patient tolerance, tissue type radiated, fraction site, and concomitant treatments like surgery, chemotherapy, especially surgery. These all impact fibrosis in patients who have been treated for head and neck. Pathophysiology, I'll keep it short. It is production of myofibroblast, and then in turn production of excess collagen and different constituents of extracellular matrix, which is aided by reduced secretion of the remodeling enzyme. Various factors, neutrophils, expression of ICM1, TGF-beta, some of them have been discussed, direct DNA damage, and reactive oxygen species, hydrogen peroxide, hydroxyl radical. These are all factors which enhance fibrosis. This slide we have discussed before. Risk factors, apart from all that we discussed, like treatment size, the treatment time, the duration, the dose, the fraction size, there are certain genetic factors which are important. So, what is the temporal classification of radiation fibrosis syndrome? It is acute, early delayed, which is up to 3 months after treatment completion, or late or chronic, which is more than 3 months, which has a poor prognosis and which is irreversible. Histological phases, it is pre-fibrotic phase, it's then the organized fibrosis phase comes in, and then there is late fibroatrophic phase comes in. By that time it's actually too late. Clinical manifestations, we all know, we will not get into the details of this. Long-term complication, apart from progressive thickening of skin fibrosis, subcutaneous tissue, muscle fibers, ligaments, they're all getting affected. There is other clinical constitutional symptoms like fatigability, weakness, myopathy, painful spasm, etc. So now let us come to specifics, which since this is a general audience, but let us talk about some specifics. Swallowing dysfunction. So dysphagia and swallowing dysfunction is a very important aspect of radiation fibrosis. Primary radiation, but some studies have shown addition of chemotherapy also enhances late swallowing dysfunction, and how to prevent it or how to score over it we will be talking about. Late dysphagias and aspiration, they usually start months or years later and may decrease in around 1/3 of the patient, remain unchanged in 2 out of 5. There's a particular study, it's Dupré study, and worsen in 20% even with therapy. So as I was saying, we are of late talking about dysphagia optimized radiation therapy. So you contour out the DARS, which is soft palate, all your superior constrictors, middle constrictors, inferior constrictor, glottis, supraglottis, and you save radiation doses to those structure. If you look at the picture on your left, all those constrictors are being radiated. If you look at the picture on your right, your constrictors are being spared. But is it as simple as it is? So a lot of expertise, it is challenging, and it takes years to get to this kind of a radiation therapy profile. Carotid stenosis is also actually a part of radiation fibrosis, and this is a particular study where the control group, which was surgery only, had lesser percentage of carotid stenosis than the patients who underwent radiotherapy. Again, the solution for this is carotid sparing, IMRT, and image-guided radiotherapy techniques. Trismus. Trismus for oral cavity and oropharyngeal patients, it is a major problem. It is because of the contracture of the mastication structures, masseter, pterygoid, neuroinnervation, temporomandium joint. So they all get affected. And it is, your swallowing function worsens because of that. Intake becomes poor, electrolyte imbalance. So again, in a particular study, they have shown that techniques, the modern techniques like IMRT, can bring down the rate of trismus from 25% to 5%. Osteoradionecrosis is also a type of fibrosis in head and neck cancers. And of course, we know it's the necrotic process of bone that results from high dose radiation. Apart from conservative management, if you get onto osteoradionecrosis, it's better that it's a surgical treatment. So the answer is better that do not get into a situation when the patient will have a osteoradionecrosis, because it can really become cumbersome for the patient. So essentially what I have been talking about is all this requires hospitalization. The intake of the patient comes down. There are electrolyte imbalance, counts go down, patients require feeding tubes, and so hence there is a lot of quality of life related issue. So prevention is better than cure. As I have said, treatment with modern conformal radiation techniques in the last decade has come out to be the best preventive and of course therapeutic measures. Of course, avoidance of certain chemotherapeutic agent, avoiding local trauma, avoiding alcohol, certain medications, they all add on to prevention. Therapeutics, anti-inflammatory, vascular-directed therapy, hyperbaric oxygen, antioxidant, cell-based therapies, and other treatment. Anti-inflammatory, we all know, NSAIDs, steroids, we will not get into the details of it. Vascular-directed therapy, pentoxifylline alone or in combination. So there have been a lot of studies with pentoxifylline alone or with vitamin E and various other agents, which has shown benefit in 15 to 20% patient. Hyperbaric oxygen, again, has been a therapeutic measure which has shown improvement in around 20% of the patients. Superoxide dismutase has shown encouraging results in a series, in 2 or 3 series, which has shown improvement in 30 to 50% of the patient. Vitamin E, as I said, with combination with pentoxifylline, various studies have shown some results, and there are single arm studies and improvement in around 30 to 40% of the patients. So this is a table which is tabulating the effects of all the agents which are extremely effective, which are moderately effective, and which are not so effective in radiation fibrosis. Of course, you have to treat symptoms like pain. Physical therapy is an important part of management of radiation fibrosis, and few issues have been discussed about it before also. What I want to finally come at is the conformal techniques, because we have been struggling with radiation fibrosis for a long time. And yes, pentoxifylline and tocopherol, they all help, but not to the extent that we want to. So prevent, make your beams conformal, do not radiate tissues which are not to be radiated. And the take home finally is prevention in a radiation fibrosis setting is better than cure. Supportive care is of utmost importance. Let us work together for enhancing the quality of life, because finally the quality of life of the patient is what matters. And whenever recommended, evidence-based, and can be used with recommendation, use conformal and precision techniques and do not radiate tissues which are not to be radiated. Thank you.